we didn't want our patients to die when we were on duties. When I was doing a fellowship candidate, there was a rule that if the patient dies in your shift, then irrespective of whether you are finishing your shift or not, you should finish the death summary. So invariably, we used to give adrenaline bonuses before the shift used to get over, and then push out. I just wanted to actually ask seniors, we had a discussion whether should we continue with this talk or not, especially considering the match going on, so many. Okay. Right. Since yesterday, almost all the speakers, irrespective of what the topic was, whether it was fluids, whether it was ventilation, whether it was antibiotics, everybody emphasized on one part, and that was individualize your therapy. And every aspect of intensive care probably holds good, and maybe there is nothing as far as intensive care is concerned today where you can blindly say that these guidelines will be applicable to all of my patients. Similarly, even to the intensive care nutritional aspects, I think yes. Are personalized prescriptions the key? The answer definitely is yes. Do I have the master key? Probably not. Why do we need to individualize nutrition? Very simple. Critical care in itself is an extremely heterogeneous group of patients, and the time course is very, very dynamic, it's variable and unpredictable. So when you have such a group of patients where the metabolic changes are going to be very, very unpredictable, similarly your caloric needs are going to be unpredictable, your caloric demands will be varying, your protein requirements may not be similar. You cannot apply a simple formula based caloric or protein requirements because they will not be applicable to all your patient subsets. The most important part is the extreme variability in energy expenditures. Different patients have different energy expenditure. And another very, very important thing that determines how these patients are going to respond to your nutritional interventions is both the genetic makeup and the prior nutritional status. There is very, very clear data which suggests that the benefits as far as nutritional interventions are concerned seem to be the most in the patients who are at the highest risk of malnutrition. I'll present the data as we go through the talk. We need to look at critical illness from a different concept, mainly from the metabolic model of critical illness. Now, if you look at the metabolic concept, you can divide the course of a critically ill patients into 4 stages. The first is the acute critical illness, which happens in the first 24 to 72 hours. Now, this is where your natural Darwinian evolutional concepts come into picture. So, whenever you have an insult, whenever you have some kind of trauma, your body responds as a defense mechanisms. There is a typical fight or flight response where there is significant sympathetic response, there is elevated release of your stress hormones, and that lasts for the first 24 to 72 hours. Now, in the natural course of the disease, if you do not get the patient to the hospital after 72 hours, either this response will protect the patient, heal the patient, or the patient is going to die. But when the patient is brought to the hospital, that's where we start to intervene, not only with the natural course of evolution, but also our interventions may modify the metabolic progress of the disease. For example, after the first 72 hours, what we get is the prolonged acute critical illness, where you can have some amount of immune paralysis. You still have hypercortisolism, but this depends upon what kind of interventions you do. After this, you have the chronic critical illness, which is generally prolonged mechanical ventilation, where there are multiple metabolic changes. The usual onset is about after 1 to 2 weeks of admission, and the patient, if he is lucky enough, has a final stage which is recovery from critical illness, which begins usually with the liberation of mechanical ventilation, and there the quality of life will be determined. Now, what you do here with your nutritional interventions will determine what happens there. It's not only the acute disease, but the prior nutritional status and the relevant comorbidities which determine what happens at the rehabilitation phase. So if you're looking at nutritional interventions to improve your mortality in the first few days, that's not going to happen. So your idea of nutritional interventions should be to look at what will my nutritional intervention do to my patients at this stage. So if you have a patient who is going to stay in the intensive care unit for less than 4-5 days, your nutritional intervention is not going to make much of a difference. Whatever nutritional intervention has to make a contribution or difference is going to be in those patients who are going to stay in the ICU for more than a week's time. Now, coming to the various components of how can we individualize nutrition, the first thing would be to have a clear assessment of what the nutritional status of your patient is. Try to have an accurate assessment of his energy expenditure. I'll go through the various components in detail. Look at what's happening to his proteins, evaluate his gut failure, glucose tolerance. Is the patient on any extracorporeal interventions? Because there's a significant amount of nutrients that can be lost when the patient is on any extracorporeal therapies. Do not forget to give your patients the dose of micronutrients, because as the time progresses, these patients tend to have significant micronutrient deficiencies. And never forget the contribution of non-nutritional calories. Just to give an idea of malnutrition in the intensive care unit, this was published in the Wall Street Journal. Between 2007 to 2008, about 150,000 Britons entered hospitals with malnutrition, and at the end of 2008, about 8,000 more patients had left the hospital with malnutrition. That means to say that there were about 8,000 patients who did not have malnutrition when they came to the hospital, but when they were discharged from hospital, they were malnourished. Isabel Correa published this paper where they looked at the impact of malnutrition on morbidity, mortality, length of hospital stay, and cost evaluated. And they found that patients who were well nourished seem to have lesser complications in terms of decreased infections, tend to have a decreased mortality. The mortality was 12.4 in the malnourished group as compared to only 4.7 in the well-nourished group, and they spend more times, about 16.7 days as compared to only 10.1 days with respect to the malnutrition. So any patient who is malnourished tends to have a higher rate of complications, mainly in terms of infections, has a higher tendency of having more morbidity, and has a higher chance of dying. Now again, when we look at various factors which contribute to malnutrition, now there are certain personal factors, probably you may not have much control on that, but when they looked at the organizational factors, lack of nutritional screening or lack of assessment was one of the main contributing factors for leading to malnutrition in the critically ill patient. So until and unless you look for malnutrition, there is a chance that you are going to miss that, and eventually your patients may have a higher chance of getting malnourished. Now what are the various scales that can be used? Subjective global assessment, very simple, based on a questionnaire. You can categorize your patients as either well nourished, moderately or nourished, or severely malnourished. Currently this is what we are using in our ICU. There are other systems which have been validated by the ASPEN 2016 guidelines. One is the Nutritional Risk Screening 2002. Again, if you look at the various severity scoring patterns, the mere admission to the intensive care unit with an Apache of more than 10 falls into the criteria of having a risk for malnutrition. You need not have all other risk factors, just the mere admission to the intensive care unit and having a Apache of more than 10 puts your patient at risk for malnutrition. The last scoring system which has been validated by ASPEN 2016 is the Nutrix 6. There are two categories. One, if you have IL 6, the score is between 6 to 10. If you don't have IL 6, the score is between 5 to 9. Again, extremely important to note that patients who had a high score had worse clinical outcomes in terms of mortality and ventilation, and the benefit with your interventions was mostly seen in patients who were at a high risk for malnutrition. So, if you have a patient who is at a very, very high risk of malnutrition, now those are the patients where your nutritional interventions are going to work, and those are the patients where probably you would do a lot of good by giving aggressive nutrition. So the first step in individualizing nutrition is to have a risk assessment and stratify your patients either into low risk or high risk, because once you do it, then probably your interventions will be concentrated on patients who are at a very, very high risk, and those are the subgroup of patients who will benefit with your interventions. The next most important and the most debated question as far as nutrition in intensive care is concerned is about the appropriate calorie intake. Now, what do you mean by appropriate calorie intake? Appropriate calorie intake is nothing but trying to match your caloric intake which is equivalent to your energy expenditure. Now, as I have said before, the energy expenditure in the critically ill patients is extremely variable, extremely dynamic. So, when you have such a subset of patients where your energy expenditure is very, very variable and very, very dynamic, using a fixed caloric goal, probably you will never be able to meet the actual energy expenditure of that patient, and that could be one of the major limitations in personalizing your nutrition prescriptions, because as of now, universally we do not have a tool by which you can accurately and on a regular basis assess what is happening to the nutritional expenditure on a day-to-day basis. Now, if you look at various studies, excellent review by Point published in the J10, they found that when we use predictive equations, for example, the Harris-Benedict equation, Ireton-Jones, there are more than 100 equations to calculate the energy expenditure. Now, if you use those equations to guide your energy requirements, then there is 80% chance that you may get it wrong. So, there is an 80% chance that either you overfeed your patient or you underfeed the patients. And again, there is robust data to suggest that overfeeding is bad, underfeeding is bad. You have complications by overfeeding in terms of hyperglycemia, in terms of increased infections, in terms of increasing the ventilatory load. So you don't want your patients to be overfed. At the same time, there is again a lot of data which has shown that if you underfeed your patients, then the chances of having a poor outcome is much, much higher. Similarly, there is also data published from Helan's group that if you can reach your calculated nutritional or calories, if you can have a clear understanding of what is the energy expenditure, and if you can reach those goals, then the outcomes can be much, much better. So, this is again an excellent review by Kramer, where they looked at, they tried to measure the resting energy expenditure among different cohorts of patients, among which there were healthy volunteers as well. The dark squares or the dark blocks are the patients with various pathological diseases, and the white blocks are healthy volunteers. Now, if you look at the resting energy expenditure, you find that patients with various pathological diseases, the resting energy expenditure varied from as low as 19 kilocalories per kg per day to as high as 45 kilocalories per kg per day. That again tells you that there is no way of exactly knowing what is the energy expenditure until and unless you have a precise way of measuring the energy expenditure. Similarly, if you look at the total protein loss, the protein loss again was extremely variable from as low as 0.6 to as high as 2.8 grams per kg per day of the body weight. So, just to emphasize the fact that the energy expenditure and the metabolic demands of patients who are in the intensive care unit cannot be uniformly assessed or uniformly put into one place by a simple formula or whatever, until unless you have a technique where you can be very precise in measuring what the energy expenditure is. And based on this, most of the guidelines, including ASPEN 2016 guidelines, have very, very strongly recommended the use of indirect calorimetry whenever it is available. But most of the times, indirect calorimetry may not be available. It also has its own limitations, confounding factors which may not be applicable to all intensive care unit patients. So the best situation that we are left with is to use a ballpark figure. The rule of thumb as proposed by Pierre Singer is, if you do not have indirect calorimetry, then you provide 20 to 25 kilocalories per kg body weight in the early acute phase, and you increase it to 25 to 30 kilocalories per kg in the stabilized patients. What we need to remember here is the caloric needs are slightly lower in the acute phase, mainly because there is a lot of endogenous substrate which is released during the acute phase, and because of the endogenous substrate release, there is a significant endogenous calories which are produced. So if you give a higher calorie in the initial stages of acute illness, then there is a very, very high chance that you may actually overfeed your patient. So the next most important step in the process of achieving personalized nutrition plan is to accurately and repeatedly assess the energy expenditure and have a strategy to match the varying caloric needs of the critically ill patients. In the idealistic situation, this is possible only if you have indirect calorimetry. If it's not there, then probably err on the side of giving slightly lower calories in the initial stages because of the endogenous substrate production and endogenous calorie generation, and try to give a higher calories in the later stage when the patient is stabilized. The next most important component of a nutritional plan are the proteins. Now, if you look at the amount of proteins which are lost, data is very, very clear that the amount of proteins which are lost during the first 10 days is the maximum, and the protein loss is directly related to the number of organs involved. There is almost 16% protein loss when the patient has multi-organ dysfunction as compared to only 3% when the patients have only one organ dysfunction. And if you translate this protein loss into the loss of lean body mass, it amounts to as high as 2.5 to 9 kilograms of lean body mass loss. And the entire goal of nutrition is to try to preserve this loss of lean body mass, because that determines your outcomes as far as nutrition is concerned. And all this happens within the first few days of ICU admission. Proteins are the key. We need to identify the factors which are responsible for anabolic resistance. Anabolic resistance is basically the mechanism by which whatever proteins you give, those proteins are either diverted towards oxidation or diverted towards metabolism or formation of acute phase reactions, and they don't get involved into protein synthesis. So there are significant factors like probably the inflammatory response. Maybe you can't do much about the inflammatory response. There is nothing much that you can do about aging. Insulin resistance and hyperglycemia, yes, there are ways of maintaining your blood sugars within the target limits by which you can probably have a method by which you can counteract anabolic resistance. Use of steroids again significantly contributes to anabolic resistance. Inadequate energy intake, as I said, is a significant factor towards anabolic resistance. Chronic diseases, probably nothing much that you can do about, but immobility and physical inactivity contribute significantly towards anabolic resistance. So there are certain strategies which are still available with us which can help us fight against anabolic resistance, and that those are the factors that you need to identify in your patient subgroups and try to see if those factors which are contributing to this anabolic resistance can be modified or not. Excellent observational study where they looked at day 4 and day 12, what was the energy intake and what was the protein intake. The actual protein prescription was about 1.2 grams per kg per day. That was the protein prescription that was supposed to be delivered to the patients. Now when they looked at the day 4 sample and day 12 sample, in neither of the groups were they able to achieve the target of 1.2 grams per kg per day. But when they looked at the data, they found that those patients in whom at day 4 sample, the protein intake gradually increased, the risk of mortality came down significantly. And this was very evident in patients who had a very high Nutric score. That means to say that even if you are not able to achieve, ideally you should be able to achieve the prescribed protein targets. But even if you are not able to achieve, when there was an increase in the protein intake, patients with a high malnutrition risk score had better mortality. The finding was similar at day 12, where the mortality significantly decreased in high risk groups when the protein or the percentage goal protein intake was increased. The PERMIT trial published in the NEGM, where they compared two groups of patients, one who were deliberately underfed, where they gave only 40 to 60% of the calculated calories, versus they gave the complete 70 to 100% of complete whatever calories were calculated. The only difference was both the groups were given similar proteins of 1.2 to 1.5 grams per kg. And when they analyzed the data, they found that there was no significant difference in terms of mortality. So even in those subgroup of patients who were given lesser calories but were able to meet the protein requirements, the mortality was similar to those patients where the caloric goals were met as compared to those where the caloric goals were not met. Excellent review by Ruyackers, where they analyzed all the studies where protein was one of the major interventional strategies in nutrition. They found that if you are giving a protein beyond 1.8 to 2 grams per kg, probably there is not much of benefit. There definitely is a benefit when you are giving a target of 1.2 to 1.5, which is the current recommendation by both ASPEN and ESPEN. Giving a higher protein beyond 1.8 to 2 grams per kg per day probably may not give much benefit. However, there has been no harm that has been attributed to a high dose protein intervention. So the third most important step to make sure that the patients get adequate nutrition is to ensure that the protein requirements are met. The fourth thing which interferes with our prescription delivery of your caloric targets and protein targets is your gut intolerance. Again, excellent study published in the JPEN, where they looked at what was the effect of feed intolerance on calories, on proteins, on the outcomes in terms of mortality and in terms of length of stay. So what they found was those subgroup of patients who were intolerant to the feeds had a significantly decreased calorie delivery, had a significantly decreased protein delivery, had a significantly increased ventilator days, had a significantly increased 60-day mortality, suggesting that if your patients are not tolerating feeds, then probably you are dealing with a much sicker group of patients. At the same time, suggesting that if your patients are not tolerating the feeds, then there is a very high chance that whatever nutritional prescription you give, you may not be able to achieve it. Simple techniques which have been suggested to improve gut tolerance is early feeding. The best stimulus to move your gut is early enteral nutrition. Make sure that electrolytes are within normal limits. If you are not able to move your gut, think of using prokinetics. Minimize the use of sedations, especially opioids wherever possible. If gastric feeds are not tolerated, you can think of using post-caloric feeding and think of using continuous feeding, and early mobilization and physiotherapy seems to play a major role in making your gut work. So the next step would be to ensure that your gastrointestinal tract works, and the best way of doing it is to start your feeds very early, because that's the best stimulus to make your gut work. Glucose control, I won't be going into the details of that. As I said in the previous slides, hyperglycemia is an independent predictor of both your anabolic resistance, increase the risk of infections, and can interfere with your delivery of nutritional formulas. There have been numerous trials which have looked at what should be the target goal for your blood sugar controls. Now we have all accepted that moderate glycemic control of less than 180 seems to be appropriate. So optimize your glucose control, that would be the next step. Micronutrients, as I said, there is a tendency for loss of vitamins and trace element deficiencies when your patient spends a larger amount of time in the intensive care unit. This deficiency is exaggerated when the patient is on RRT. So you need to ensure that all your micronutrients, vitamins, especially proteins, are toppled up whenever they are on some sort of extra corporeal therapies. So remember to supplement your micronutrients, because loss of protein and water-soluble microvitamins through renal replacement therapy is very, very significant. Lastly, do not forget the relevance of non-nutritional calories. Dextrose gives about 4 kilocalories per gram and propofol gives about 1.1 kilocalories per ml. So if you are using dextrose as a fluid to dilute your medications or dextrose as a maintenance fluid, there could be a significant amount of calories which can be coming from dextrose. Similarly, if you are using propofol as a sedative agent, please keep in mind that that can contribute significantly to the caloric load. And if you have a unit where you are using trisodium citrate as your anticoagulation for CRRT, then in this study they found that the non-nutritional calorie contribution from citrate was as high as 18%, which is very, very significant. So please keep these things in mind. So just to summarize, if you are having a patient with obesity, I think in any of the subset of patients, the best way of assessing your energy expenditure would be indirect calorimetry. If you do not, then most likely you will be guesstimating what the energy expenditure would be. But a word of caution, in the initial acute stages, probably it is better to target lower calories because there is endogenous substrate production and you may have a risk of overfeeding these patients. Make sure that the proteins are high, protein goals are met with. The way we do it in our ICU, the team that is taking care of the critically ill patient has to be sensitive to the importance of nutrition in critically ill patients, because this is a team approach and everybody who is in the team should know the importance of nutrition in the intensive care unit. For us, a clinical nutritionist supervises the nutrition plan with input from the ICU team. Currently, we are using the subjective global assessment, but we are moving to Nutric. We are online system, so we are just making the changes to move to the Nutric way of assessment, Nutric scoring. We do not have indirect calorimetry, so we are just going with whatever current recommendations are there. But what we do is we reassess the prescription and delivery at the end of the day. At the end of the day, the nutritionist calculates what was the prescription which was given, calculates the amount of calories which were given, calculates the amount of proteins which are given, and whatever deficits were there, we try to catch up the next day. We identify the interruptions, try to train the nurses. It's been always an ongoing process that never ends, and we try to revise targets based on the clinical status. We are a unit where we follow a high protein formula. We try to give at least 1.5 to 1.8 grams per kg per day. For that, we try to use different combination of feeds and protein supplements. Probiotics, if the gut doesn't move in the first 24 to 48 hours, usually come on board. We are very, very particular about our electrolytes, and usually the best way of replacing your trace elements and water soluble vitamins would be if you have some way of monitoring their levels. Since we do not have a way where we can laboratorically monitor the levels, probably the best way would be just to supplement them. Thank you. We advise formula feeds. All patients in the ICU. Yes. No, I mean there's more chance that they may be intolerant to your kitchen feeds than your formula feeds. See, for kitchen feeds, you need to have an absolutely sterile kitchen. You need to be very, very sure about what kind of caloric content or the nutritive content of the kitchen feed that you are going to deliver. You need to be absolutely sure about that. And then you need to have a kitchen which works continuously, because feeding starts in the morning and then until unless you are a unit which follows bolus feeding. Just a small announcement. Customary vote of thanks. At the outset, I would like to thank the faculty who have always been with us for the last 10 years, and whenever we have organized the conference, the faculty have always been very, very eager and have always taken time to come and give their best. Thank you. The delegates, as Srinivas has said during the start of the conference, no matter what kind of scientific program you organize, until and unless you have the delegates, your program is not going to be success. And the testimony to that fact is that we still have a significantly large number of delegates who are sitting here despite the Champions Trophy finals happening. I would also like to take the opportunity to thank the sponsors, Anish, Pfizer, Abbott, Fisher Pickle, Smiths, Fresenius, and Dr. Reddy's Laboratories. I would also like to thank the ISCCM Executive Committee for endorsing the program and allowing us to go ahead with the ISCCM endorsement. I would like to thank all the teachers of ISCCM in Hyderabad and across the states for allowing the students to come and attend this program. I would like to thank Mr. Pratap Jain for the excellent audio-video support that he has given us. I would like to thank Mr. Ashish Jain, Lavanya and Tipu Sultan from India CME for an excellent live web streaming of the entire program. The reviews that we have got about the web streaming has been phenomenal. And lastly, I would like to thank my team, without whose support probably this program would never have reached 10 years of our beginning. And a special thanks to Anil and Madhu. Anil, who has been the single point of contact for taking all the registrations, trying to clear the inquiries, the questions, the doubts of everybody, and who is sitting out there and probably taking a lot of cursors from delegates for not giving the certificates because he is waiting for a nod from us to deliver the certificates. Thank you once again for all of you for coming over here and making this a fantastic success. Thank you so much. I invite everybody to join us for a cup of tea with snacks, after which you can take your certificates for which you have been very eagerly waiting. Thank you.